ones, I think I told you, were like the generic TP snub. That's this one up here at the top, because that one can be used with a mouthpiece and an aerosol mask, which you guys muddled with a little bit, and then also in a ventilator circuit. So we can give it to patients that have a circuit. So there was a question on Friday, like, what's a circuit? So the circuit is the big blue corrugated tubing, and it can be heated or unheated, okay? So we either plug it into a heater, right, where we put the power cord in the back, or we don't, like you set up for the large volume nebulizer and it's just plain tubing, okay? That's unheated tubing. You can still heat the large volume nebulizer like you all did. You guys screwed it into the bottom right, put your temp probes in, you saw that it got warm. But you didn't actually heat the tubing, and that's what I'm talking about, a heated circuit. It actually has a heated wire in it versus an unheated circuit does not. Okay, and then the other one you'll see frequently is this one over here with the green top. That's the Aero Eclipse, and you guys will get to play with those today. Those are the two most common. Some hospitals will have these. They're called breath enhanced nebulizers. So is actually these three in the middle are all breath enhanced nebulizers. We'll talk how those work. And we can use these with mouthpieces. They don't work with masks. Because it requires you to pull air through the device, and when you have an aerosol mask on, you have giant holes in the side of the mask, and so you're not really entraining air through the device, okay? And this one down here on the bottom left where it says PARI, P-A-R-I, PARI LC+, this is a home care neb that we give to patients, or patients get at home, and we use that for specific medications, okay? And it's also an air entrainment style mask, and we'll talk about how this works. So this is a diagram just to help you kind of understand how these work. The Misty neb in the top left, this is the same as the generic T-piece, okay? It's the same thing. Sometimes they're called Misty Max nebs. That's just like saying I have a pair of Nikes versus a pair of Reeboks, or I have Nikes versus sneakers. Like I have a Misty Max versus T-piece. So it's just a specific type of T-piece neb. So the power comes out at the bottom. This is completely empty, but it would have the baffle and the capillary tube, right? And this is the medication cup. And then this is where the T-piece is, and we inhale and exhale out of that mouthpiece, and then we have a small piece of blue corrugated tubing at the end, correct? Mm-hmm. And what's that for? What's it act as?
A reservoir.
It's a reservoir, right. So that's where medication collects so that when I inhale, I get a nice big dose of that. Okay, the side stream, that's this one, and I'm gonna go back to the previous slide. So a side stream is like the middle ones here. Okay, so the middle, the bottom, and the bottom right. Okay, so the top, middle, the bottom, middle, and the bottom right. Those are side stream nebs. And what happens with these is you'll see up here at the top, instead of being closed like in the Misty Max or the T-piece, it's open, okay? So these generally use a lower flow. Do you remember what flow you put your T-piece neb at? 8. You put that at 8 liters per minute, okay? These generally run at 6, okay? These entrainment masks, they typically run at 6. So what happens is the patient inhales, this side stream, or this inlet right here, allows air to enter into the medication cup and accelerates aerosolization of the medication, okay? And so there's less aerosolization during exhalation, an enhanced amount of aerosolization during inhalation, and then they get a larger dose that way. All right. Okay, so this PARI LC Plus, the one over here on the right, okay, that's the one down here. That's the home care neb. Okay. It works similarly, except that the air vent is at the top. And instead of breathing through a T-piece, we breathe in and out of the same, okay? Except in here, there's a one-way valve for exhalation. So as you exhale into the device, it just blows out of the mouthpiece. So if I back up here, you'll see this little blue valve here, right? So as I exhale, it comes out the blue valve. As I inhale, air comes through the top of the device, accelerates the aerosolization, and I inhale that medication. Okay. Then the only other one that you'll work with is down here, the Aero Eclipse, and that's the one with the green button on the top, okay? It's an entrainment device as well, and it has a one-way valve on the mouthpiece as well. So this can work in 2 ways. It can work in both continuous and breath actuated, okay? So those 2 different modes, you get to play with them in the lab. The breath actuated mode only aerosolizes as the patient inhales through the device. That's the only time it makes medication. The continuous mode, of course, creates a continuous aerosolization, right? And then if you remember, I'm just gonna flip you back from memory to this slide here, okay? This device is the one I'm talking about with the green top, has a significantly higher value of aerosolized particles, right? So the size of particles it makes, rather than being extremely heterodispersed, it's still heterodispersed, but in a much smaller range. So more of the particles make it to their intended target, right? So you can use this device in continuous mode, and you can use it with a mask, right? All right, then this one down here, the circulaire, is a device in which you breathe in and out of a bag that acts as an aerosol. I've never seen one of these in use in clinic, but they talk about it in the text, but don't expect to see this out in the field, okay? All right, other things, ultrasonic nib, we've talked about quite a bit. Remember, this is our keyword right here. Anytime you see this word, you want to know that we're talking about ultrasonic nebulizers, okay? So if it says piezoelectric, you're like, that's an ultrasonic nebulizer. These are typically used in home care, and sometimes we can use it in the pulmonary function testing center. I don't think I've ever used one in acute care, okay? It's gonna be more home care oriented. You guys have these at home, we talked about this, your ultrasonic nebulizers that you use when you're sick, right? And they make this kind of misty cloud, okay? They can create heat though, which means that we can't use it with every med. All right, then we have what we call mesh nebulizers, okay? And the mesh nebulizer that we have is called the Aerogen, and we get to play with that one in the back during your lab. There we go, okay. So mesh nebulizers are really great because they don't allow a high level of residual volumes. Remember, residual volume is what's left over after the nebulizer has run. And the active mesh is run by electricity, okay? So it's not run by pneumatic power. Now, many of you will be like, who cares? I know that's always Miranda's question. Why does it matter? Right, why do I need to know this? All right, I hope all of you memorized what this was. This is going away. All right, so what happens with a mesh nebulizer, and I know that we have one in the back, okay? The mesh is like a disc like this, okay? And it's really tight wire, like a mesh, okay? It's very, very small, okay? That's what it looks like. But it sits like this, okay? So this is the, you put the medicine in here, okay? I drew that in there. Anyway, so you get the idea of what that looks like, okay? All right, so then what happens is the medicine sits here, and this is the disc right here, and you provide power to it. And all it does is it vibrates very, very quickly, okay? Vibrating mesh. And the vibration through this mesh, this tight mesh, shakes the aerosol, shakes the liquid into aerosol, into a real fine mist of aerosol, okay? Now what can happen is this can either be going to a mouthpiece, all right, so you breathe in and out of it, or we can put it on a circuit. So this would go on the heater pot as well, okay? Now, if it's on a circuit, we put it on what we call the dry side, okay? So, out of, you know, the number of markers I replaced up here, I can't believe that there's still markers up here that don't work. Where do they all go?
They don't send me behind it.
Up here?
Yeah.
I know, but they're like orange and stuff, and then y'all can't see. I think Dr. Z walks over there. Oh, they're back there. All right, so this is on the dry side of the humidifier. So this would be from the blender. Okay, it goes this way. And then it goes out to the patient. Okay. So we call it the dry side because it's air that's not humidified. That's what's first, right? then it goes across the water and it comes out humidified, agreed? Okay, so that's why we call it the dry side. Okay. So anytime you assemble it, the nebulizer will go on the dry side. Part of that is because if you don't, it messes up the temp probes. I think research says it doesn't really matter, but this is the preference, okay? All right. All right, sorry. Let me deal with this lady. Okay. Alright, so they're very efficient. Alright, so the passive mesh where an ultrasonic horn pushes fluid through, we don't use those. But they do exist, but we use the active ones where we have, that it actually shakes, okay? And you get to play with them. Alright, the next one is called a SPAG, S-P-A-G. Now, we rarely use these in clinic, but they always pop up on the board exam. So you really do need to know what this is. Okay, a SPAG nebulizer is for the medication called ribavirin. And that's the only medication that it uses, ribavirin. Okay, so this is always going to equal SPAG. Okay, now I know in clinic, sometimes if they use ribavirin, which is very rare, but if they do, they're sometimes putting it in this, which is a vibrating mesh or what we call the aerogen. Sometimes they do that. But on the MBRC, SPAG and ribavirin go together, okay? Ribavirin is specific for the treatment of RSV, respiratory syncytial virus. So those three things will always go together, and this is what the SPAG looks like, okay? SPAG is like, it's a specific aerosol generator. So the medication ribavirin comes like a powder. We have to reconstitute it, and then we put it in a jar right here that would sit right here, and then we aerosolize it to the patient, okay? But we don't really use it all that often anymore because we can't really help kids with RSV in that fashion. RSV doesn't respond well to ribavirin in terms of clinical outcomes, okay? So kids with RSV, we do what we call symptomatic management. We do whatever makes them feel better. We can't shorten the course of an RSV infection. We can just make children feel better while they're there, okay? All right, another type of nebulizer is what we call a filtered neb, or the brand name is called Respigard 2. It's used with a medication called pentamidine. So anytime you see the word pentamidine, that's an anti-infective medication, so it helps deter lung infections of a specific bug. We'll come back to that, but know that pentamidine is an anti-infective medication, and it is always given with what we call the Respigard, or a filtered nebulizer. And I have another picture of this, but what happens in a filtered neb is the medication goes down here in the neb cup. You can see this just a generic T-piece neb cup, but it's full of one-way valves, okay? So as the patient inhales, we inhale through the reservoir, just like we always would, but when we exhale, it's exhaled through this filtered space, okay? And that's because we don't want pentamidine out into the air, all right? When you give pentamidine, the other two things you need to know, not only is it with a filtered neb, you must wear an N95 mask as the provider, and you should be giving it in a negative flow room or a negative pressure room, okay? So pentamidine anti-infective is given with the Respigard 2, which is filtered neb. I need an N95 and I need a negative pressure room. Those are the 4 things you need to know for an MBRC hospital, okay?
Why is it so, why do they have those standards set?
Pentamidines are really, typically we give it to patients that have chemotherapy, and it's an attempt to deter fungal infections for patients that are at risk. You don't want the medication because it can have adverse effects, okay? So if you don't need it, you don't want it. Pentamidine's given once a month for patients that are high risk. Does that answer your question?
Mm-hmm.
Okay. All right, we have a couple options for continuous aerosol. So what types of patients would get continuous aerosol of albuterol? we're talking about, so you had continuous aerosol before, right? That large volume nebulizer provided continuous aerosol, but it was bland, right? What made it bland aerosol?
There was no medication.
There's no medicine in it, right? It's just humidity, okay? Typically sterile water, okay? So now we're talking about a continuous aerosolized medication, okay? The most common one that we use continuous is albuterol. What does albuterol do? Do you remember?
Does it help open up the bronchi?
Yep, it's a beta-2 agonist that helps smooth muscle relax. It causes smooth muscle relaxation. So now we're really gonna start talking about what do meds actually do, not just what do I need them for. Okay, so we're gonna put albuterol up here in the corner. I'm gonna see if there's a dark color back here.
You can use this one now.
What's that?
You got one? Okay.
I got it. Oh, see, here's another one. I probably left this over here. It's my own fault, per usual. Alright, so we'll start writing the big important ones up here. So we have albuterol. Okay, sometimes it's these are the brand names. And the MDI is red, usually, okay? This is what we call a beta-2 agonist. And it causes smooth muscle relaxation. Okay. This is the common name. It's a short-acting medication. So short-acting, that means it comes on quick and it wears off fast, okay? We're gonna talk about this one a lot. So when it's a short-acting beta agonist, it's commonly referred to as SABA. Okay? SABA. All beta agonists cause smooth muscle relaxation. So they take a tight muscle and they tell it to relax. Okay? It initiates relaxation. And it falls under the category of adrenergic bronchodilators, which we talk about later today, okay? All right, so we give this to patients that are having really, really terrible asthma attacks that a single treatment or 2 treatments or maybe 3 treatments just isn't cutting it, okay? So we put them on a continuous flow of this, okay? And there's a couple different ways we can do it. This up here, this picture, this type of pump is called a syringe pump. And this is exactly what it looks like in the field when you see it. It has a syringe up here with medication and then this little blue line coming through, and the screen will tell you exactly what medication you're giving it and the rate at which you're giving it and the concentration, right? This one up here on the right drips into this device, okay? So it just drips, 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 and then just continuously aerosols through the circuit. So that person is getting nasal cannula therapy, right? Heated high flow nasal cannula. We can also do it this way. This is a wide non-rebreather in which we put flow to the non-rebreather and flow to the nebulizer, and we can do it this way with a small volume neb, and it drips, drips, drips in here. This is much less common, right? The third way that we can do it is shown here, and this is with this continuous aerosol. So you can see here's our blender, or we can do it on 100% oxygen. And then this goes down into this large nebulizer that looks something like this, agreed? Okay, so this would go to the flow meter, medication drips in here, and then this creates the aerosol, okay? Or sometimes the pharmacy will just give you like a bottle of medication, and you pour it in here, and then you turn it on, and it runs for 4 hours, okay? So remember, these bigger ones up here are more commonly used for continuous nebulization. All right. So, we good there? Everybody's okay? Any questions? No? All right. So we're gonna talk about inhalers. You've all seen some type of inhalers. There's a big box of them up here. You have to know how to use all of them. Now, what's important is just like your oxygen devices, you have to understand how each device is used so that you can make sure that you recommend the right thing for your patient and you know whether or not your patient's actually capable of using the device, right? Because if you give a bunch of you like, hey, we should use these, and then the patient can't use them properly, you have not done anybody any favors, okay? All right, so advantages to inhalers is they're small, they're light, they're compact. Remember what I told you last week? Remind patients that they can replace inhalers monthly, and so then they have them in multiple places, all right? We have many, many doses in one container, all right? It's very easy to do. You get reproducible doses, so each dose is the same as long as you know how to use it. I don't have to prep the drug, and it's really hard for me to contaminate the medication, okay? Some of the downsides though is I need to have some form of coordination. Like I have to be able to push, click, open, rip, and then inhale the right way, okay? The fixed drug concentrations, which means that I might need to take multiple doses of the same device to get a better effect depending on how sick I am or how bad my asthma is, right? Majority of the medication or majority of the aerosol that comes out of a device that sprays out, remember not all devices spray, is actually propellant, and people can be allergic to the propellant, so they might not react well to an inhaler. There's a very low risk of foreign body aspiration. We get a high deposition in the mouth, which I showed you that graphic, right? A lot of medication goes in the mouth, which is not the intended target. And it's difficult to tell how many doses remain if we don't have a dose counter. So some have dose counters, okay? All right. So this is what a canister and pressurized MDI looks like. So there's the canister of medication inside, and it sits in what we call a boot, okay? There's an actuator, you shake it up, you depress it, and it shoots out this medication at a high velocity. Now read this first statement. Medication is only 1 to 2% of the aerosol emitted. 80% of what comes out of that device is actually propellant, okay? So there's not a lot of medication in each of those, which means that you really need to be very good about how the patient takes it, right? Because you have to get as much of that medication as you can. So it's what we call a press and breathe design, so you have to depress it to get the medication, and you have to shake and prime devices. Okay, so what happens here? You see there's a gas phase up here, the formulation down at the bottom. When these sit for a long period of time, propellant and medications separate, okay? And then what happens is the propellant will kind of clog up the actuator down here at the bottom. And so when we prime a device, that's when the device is brand new, or if we haven't used it for some time. Priming means I shake it and I spray it in the air, okay? And then I shake it and I spray it in the air. What I'm trying to do effectively is just clear this out until I have a good mixture of medicine and propellant, and then it will start to work properly, okay? All right, the soft mist inhalers were a bonus from the MDIs because they don't have any propellant, right? There's no need to shake and there's no priming required. So these we twist and click. And I showed you one, but I couldn't get one. I couldn't find one that had aerosol that day, so we'll work on it. But these still require quite a bit of agility with your hands and some hand strength and coordination. And so if somebody doesn't have good hand strength, or they can't keep track of the steps they're doing, or they have poor coordination, that can be difficult. To be honest with you, these remind me of little vapes. So like, you know how people click the vape and then they inhale, right? It's similar to that, except that when you click a vape device or an electronic device, it superheats the oil. This, when you click it, actually disperses the aerosol. But it's a similar type of concept. All right, so things that can help or deter an MDI from working well. Whether or not we shake it, okay? It's really important that we shake the right ones. The temperature, if they're too hot, the medicine won't work, so don't ever leave your meds in the car in Louisiana. Same thing in Minnesota, don't leave them in the winter, okay? They get cooked or frozen. All right, they can get clogged up and dirty, in which the medication doesn't come out. Timing between actuations, so we need to know how frequently to breathe on them. And then of course, breathing techniques, okay, which we talked about. Because you said, what's the difference between spraying it in my mouth, right? Versus just, wasn't it you that was talking about that? Last week, were you talking about like the inhaler and whether or not you spray it in your mouth versus the valve holding chamber?
Yeah.
Yes, okay. So we'll talk about those. So holding chambers and spacers. So I showed you them, there's still a couple of them out, right? I see a couple of them out, yep. Alright, so what was the difference between a holding chamber and a spacer? Do you remember?
Chamber gave it time to like disperse and stuff and hit the wall and then make sure you're inhaling the right stuff instead of it spraying directly like into the cheeks or whatever.
Okay, so what's the difference between the chamber and a spacer though?
Oh,
You're right.
one, they had the valve.
Yes.
One had the valve that held it and then you, breathe in after, it's like delayed or something, and then one like didn't have a valve.
Right, so what's on the table next to you? Is that a spacer or a valve holding chamber?
A valve.
Yeah, how
This
about,
is-
what's
This
that?
is a chamber?
Yep, and then you have the same one on yours, okay? Versus a spacer might just be a piece of corrugated tubing. Dun, dun, dun. And which medicines go in the spacers or valve holding chambers? Do you remember? You don't have to come up with a name, you just have to come up with the delivery. Anything that what?
Oh, is it the middle one that you wrote on the board?
Anything that sprays in the air, okay? So if I press it, it in the air, then we should have a spacer. This is a spacer, okay? All it does is create space, okay? Or a chamber, okay? But only if it sprays in the air. It's the only ones, then we need those, okay? Alright. So advantages is we decrease the amount of med in the mouth. We inhale the amount of medication by up to 4 times, okay? We can use the MDI easily when patients are having acute episodes, when they're really short of breath, because we can put masks on them and then they can just breathe at their pace. It's fast, right? I can just pull it up, put it together and go. Alright, simplifies coordination because I don't have to squeeze and inhale at the same time. I can squeeze and then inhale, so it's okay if I don't have perfect timing. Right? And because we put less in our mouth, we get less systemic side effects. Some of the downsides is, like I said last week, those are very expensive. So if you have one, hang on to it. If your patients don't have one, get them one, okay? Some of them require assembly, which makes them big. Patients maybe don't know how to use them, and they can get dirty, but. So here's the spacer, right? It's something like this, just slows the velocity down and redirects it at us. Coordination is still required, okay? Coordination is still required, significant coordination, because I still have to inhale and squeeze at the proper time. Versus a valve holding chamber, I have some timing, but I can delay the sequence and it's okay. These are expensive, and then it has what we call a signal feedback system, okay? So, there was 3 different breathing patterns that I talked about when we talked about devices. I talked about the nebulizer. Who remembers the breathing pattern when you're giving a nebulizer? How do you want patients to breathe?
Deep breath in. Oh no, regular.
Yeah, just regular breathing, right? So they just breathe in and out of the device as the aerosol is created, okay. Then I had the dry powder inhaler, so the discus, and that was the one that had the blister pack inside that when I open and then I click, that rips it apart, right? Okay, how do I want this patient to breathe, remember?
Take a deep breath.
Yeah, I gotta suck the medicine out of the device, okay? All right, and then inhalers, we talked about the soft mist one, which I inhale slowly, and then this I inhale slowly as well, right? Only when I'm using the chamber though, okay? And I'm gonna inhale slowly. So if I inhale too quickly, the device will actually whistle at me, like a stop sign. Okay, so if I take a big deep breath on it and I'm like really fast, the device actually goes. It's like, hey, too fast. Okay, so that's the feedback system. That's how we tell patients, like, oh, you're inhaling too quickly. What happens to a medication if I inhale more quickly than what it's designed for? I just erased this. We talked about where it deposits. What's that?
In the mouth?
Yeah, it's gonna end up in the mouth or the back of the throat.
Would you choke more, or like, not choke, but like cough more?
Not usually, but it depends on the patient and the illness, I suppose, but not usually. Alright, we'll practice with all of these. Alright, dry powder inhalers. So these are commonly referred to DPIs, okay? DPIs. I'm gonna give you 2 more terms that we talk about later, but I'm gonna give them to you now.
This might be a dumb question, but can you have a chamber and a spacer?
Yeah, but you'd only use one or the other, you wouldn't use them both, you wouldn't use them both at the same time. Alright, we have two different types of medication, we have relievers, and then we have controllers, okay? Some of these are called rescue meds, and some of these are called, maintenance. And they're kind of the same term. We just say relievers and controllers, okay? Alright, so relievers are used, this is gonna be the SABAs, okay? They're used in acute, need. These are gonna be long-acting medications. Okay? Now, long-acting is gonna be like 12, equal to or greater than 12 hours, okay? These help control or manage day-to-day symptoms. Day-to-day symptoms. Okay? Alright, so relievers can be both MDIs, SMIs, which is the soft mist inhaler. Okay? And controllers are gonna be DPIs, and MDIs, and SMIs, okay? There is no reliever that we give that comes as a DPI. Okay? Sorry, you can't see it, can you?
SMI or SDI?
So this is DPI, MDI, and this is SMI, soft mist inhaler. Okay. So relievers do not come in the DPI format. All DPIs are controller medications, all of them, all right? So any discus or any dry powders, anything that's shaped like this is a discus, okay? Anything that, this one too, we'll play with all of them, okay? And both sides are gonna have solutions, so for a neb. So they'll all have neb solution for the most part, okay? Now, that doesn't mean that each medication that's a controller comes in all of these formats. Does that make sense? Okay. So all reliever medications come in both MDIs and nebs, but they don't all come in soft mist inhalers, okay? Controllers come in a variety of things and they don't always cross over. So something might come as an MDI but does not come as a DPI, or might come as a DPI but doesn't come as a neb, okay? But no relievers are ever dry powder inhalers. All right. So dry powder inhalers are what we call maintenance or controller meds. They're what we give patients on the day-to-day basis to help control their everyday symptoms, okay? So that they don't feel like crap every day. So they're long-acting medications. All right, so advantages, they're small, they're portable, you have a dose counter, you have a propellant, they're breath actuated, right? I click it and I have to suck them in so I can send it out. And they're easy to use for the most part. However, the device is extremely dependent on the patient's inspiratory flow. We're not super aware of, patients aren't super aware of the dose they get because it doesn't have an immediate relief like this one does. Okay, controllers work to manage symptoms. Okay. So we have a high dose in the mouth. They're dry powder inhalers, so they're very vulnerable to humidity. Where do most people keep their medications? In a cabinet where?
In the bathroom.
In the bathroom. What else do you do in the bathroom? Shower. What's that create? Lots of humidity. How many of you ever get out of your bathroom and you're like, can't see in the mirror, right? Okay. So not a great place to keep inhalers, all right? Lots of people don't know that. They're like, oh, I do all my medicines in the bathroom. And we're like, it's a great place because you remember, right? You take, most of these controllers, you take twice a day, right? Because they only work for 12 hours, so you do it twice a day. So that's fine, except, you know, you do it when you brush your teeth in the morning and when you brush your teeth at night, except they can get humid and then that doesn't work. All right, there's a limited range of medications, although this is a growing field, and I'll show you why. Different DPIs have different drugs and different breathing patterns, so that's the other part. Okay, so here is several different types of DPIs, okay? So they have single dose, multi-unit doses, and multi-dose DPIs. All right, so for example, this is a single dose DPI. This medication comes in one dose and in one concentration. So each little pill comes out of the foil pack, you put it in the device, you take it. Majority of people who go home with this swallow the pill and have no idea what this device is for, okay? Because they were never taught. Like they order it, they go to the pharmacy, they pick it up, and they pop a pill because it's a little gel cap and they think, oh, perfect. And then they're like, my medication doesn't work. And we're all like, yes, because it's not how we do it, okay? All right, this one down here is a little bit different. So you see there's 4 doses in this one pack. We put this 4 pack in here and then we can use the device 4 times. Okay, so it's a little bit different. These might have 30 days in them, both of these. You can see there's counters on these. All right, and then on top of that, these medications down here can have 1, 2, or 3 medications in them. And then those medications can come in different concentrations, right? Mary's like, yes, you've seen these all over the pharmacy, right?
Yeah.
So we have to know like what's what, okay? Luckily, these devices down here, the brand name is called Ellipta. Okay, it's called an Ellipta device, right? We fold it over. They have done amazing things in creating continuity of care for COPD patients. So what they've done is they've made all their devices the same and then color coded them. So if a patient has multiple medications, what they've done is combined medications so that they have fewer devices, but if you need more than one device, you use each device the same way and they're color coded, okay? So it makes it a little bit easier. All right, and we have all of these things that you can look at. All right, now how do I know if my patient can actually do the work to get the medication? Okay, we have something that's called a flow check or an inflow. And what happens, and we have this, and you guys can all test each other. I have filters and everything. You okay? You hot?
No, I didn't want that stuff to start making me sneeze.
Oh.
Trying to spray.
There's something in the air, like, I don't know what's blooming, if it's ragweed or what it is, but like, I'm just like so congested. Popping allergy pills like crazy. All right, so each DPI has different intrinsic resistance. So that means by design, each one is more or less difficult to get the medication out, okay? So we just have to decide how much flow we need for the patient to effectively get the medication to their lungs, okay? And we have this, and I'm gonna find it on my first try. Everybody pray for me. Here it is, second try, okay? Alright, so I'll bring in a box of filters and y'all can check on this later. But what happens on the device right here, on this side, is a bunch of inhaled dry powder inhalers. Dry powder inhalers are on this side, okay? Mm-hmm. And then what you do is you line up the arrow, okay, with the color-coded symbol that matches the medication the patient's using. Alright, so you line it up, however that works. And then you have them breathe to see if they can generate enough flow to get that medication into their lungs properly. Okay, so you guys will get to do this later today because I have a gazillion one-way filters for you, all right? So that's how that works. Now, most people don't use this in the field. Like, I don't see this used in the acute care setting. I see it a lot in pulmonary rehab. And if your hospital has what we call a pulmonary navigator or an educator where they go and talk to patients about COPD and stuff like that, they typically have one of those just to make sure the patient can get the right medications, okay? All right. So how do I know which one to pick, right? Okay, well, I have to know if my patient can do it, what the preference is of the patient. 9 times out of, I'm gonna say 99 times out of 100, pediatric patients go home with nebulizers and kids hate them, okay? Pediatric patients can use inhalers. There's no reason why they can't. They're much more portable. They're more likely to be compliant in terms of use. and get better faster rather than sitting through a neb. But almost everybody sends a kid home on a neb, which is crazy to me. Alright, we have to know which drugs are available, if we can even combine the medications in an aerosol treatment, and then device-related factors. So what are they actually gonna use? Because the best medication to send home with your patient is the one they're gonna use, okay? That's the best one. Alright, so let's talk about a little bit about babies and pediatrics, okay?
What's peds? Like, what age range?
Well, technically, neonates are up to 30 days after birth. Pediatrics by law are under 18. So you might have a 6'4", 250-pound, 17-year-old senior in high school football player. He's gonna be on the pediatric ward, which is locked, because he's still a minor, okay? But everything we do for him is gonna be adult-sized, okay? When you talk about transitioning dosing from pediatrics to adult dosing, we're talking about onset of puberty, so it's typically arm or pubic hair. Underarm or pubic hair is when we say, okay, maybe we should start considering higher doses, because that's when the body starts metabolizing drugs differently. And there's just like going through puberty, that transition takes time. Does that answer your question? But up until 18, they'll be in the locked ward, despite their physical appearance. Because you always get a little tripped out when you go in to see a peds patient and they're like, you know, they look like a 25-year-old man, and you're like, And in some hospitals, especially the children's hospital, if you are a patient who has congenital abnormalities, maybe you had a heart surgery because your heart was plumbed wrong, or you had a pediatric abnormality, you might be seen at that pediatric hospital well into your 20s because they've done your care for so long. So it just depends. All right. So here is guidelines for device use. Infants can use a small volume nebulizer with a mask. We don't do hoods. But just look, so here it says MDI with a valve holding chamber for spacer mask greater than 4 years old. I'm telling you right now, as a person who's gonna be a badass RT, you can use inhalers on toddlers, okay, 2-year-olds. I put it on my 2-year-old, huh?
That's what I was wondering.
Absolutely 100% can do that, okay? Here's why. This doesn't work. This is an absolute no-no. This is what we call blow-by or misting a face. Where's this medication going? Everywhere but in the lungs, okay? It's in his eyes, it's on his skin, it's in his mouth. It looks like fun, he's doing it. It's completely useless, okay? So despite what you may see in clinic, don't ever do this as a practicing therapist. Turn around and be like, nebs aren't tolerated, let's do MDIs. 100% can do MDIs, okay? Now, this we can do, right? This kiddo is holding it to his face, he's doing a great job, right? This baby's sleeping, we've got a mask, but we're keeping it out of her eyes. 100% can do that, all right? Both my boys had inhalers when they were babies, and they did them all by themselves, perfectly fine by age 3. And they did great. So, and honestly, mom and dad are much more likely to carry an inhaler than they are a giant nub, right? All right, how do we keep kids safe? This is part of the infection control in the hospital as well as in home care. This pops up, so this is all on your exam as well. All right, so inhalers, we want to clean weekly. Now, they come with a cap. I'm not saying you disassemble it, but you wanna make sure that you keep it clean. So you wanna wipe it off if your mouth is on it, make sure dirt doesn't get in it, and the cap stays on it, okay? Spacers should always be washed before first use and then periodically after that. You wanna wipe off the mouthpiece each and every time. DPIs, you have to keep dry. So those we just wipe off the mouthpiece, okay? Don't wash those. Nebulizers. Okay, this is where it gets funky. In home care, right, you are gonna replace your nebulizer cup regularly. In the hospital, you may use the same neb cup the whole time you're there. Depends on how long you're there, how many medications you're getting, what medication you're getting, and what the hospital policy is, okay? For you, if you don't like how the nebulizer's performing, get a new one. Okay, so if yesterday your treatment was done in 8 minutes and today you're on minute 9 and you're not even halfway through, we need a new neb cup, okay? Don't tolerate that from your equipment, just replace it, it's not a big deal. So usually what I'll do is, when I work, I'll just put like 3 or 4 nub cups in my pocket, or on my cart, or whatever I have. And then when I come across somebody who needs one, I have one in my pocket, and I don't have to leave, come back, okay? All right, at home, what we do at home is we boil or microwave our nub carts in water, okay? Microwave them in water. If you microwave a nub cup for 5 minutes, it's gonna melt. Okay, so you microwave it in water, and then we can also put them in the dishwasher. Or we can soak it with bleach in water or alcohol in water, okay? Or hydrogen peroxide in water. So, disinfecting should be done at least once a week or twice a week as needed. Now, there are questions on the board exam about what a patient should do if they need to sterilize their nub cup at home. Okay, so have a general idea. I either need to boil it, or I have to put it in something that's gonna kill stuff, such as like alcohol or acetic acid, which is the same thing as white vinegar. Okay. All right. In the hospital, how do we avoid infection in the hospital? Well, obviously we use hand hygiene, right? Like that's the best way to do it. Okay. And then most medications will come in what we call a unit dose. Okay. So this is what unit doses typically come in little foil packs like this. So your therapist or your preceptor or yourself will go to a machine called a Pyxis, or what's the other one we use?
Omnicell.
Yeah, the Omnicell. And it's basically just like a drug vending machine. So you log in, you pick your patient, you pick your med, it dispenses it for you. Okay, this is a unit dose. So unit dose is 1 dose. So then I walk with this to my patient, I give it, I toss it accordingly, and then that's it. Next time they need a dose, I go back to the vending machine, get more medicine, okay? So that's how we deter infection spread. MDIs are not regularly used in the hospital because pharmacy does not allow us to issue, it's actually insurance. Insurance does not allow us to issue an MDI to a patient and then use that same MDI on discharge. Okay, so if this is worth 90 doses and you're only here for 3 days and you only use 10 doses, this now has to be thrown away and I've wasted 80 doses of medicine. That's a huge cost waste, okay? Which is why you don't see a lot of inhalers in the hospital. And then that's just,
you can't use it anymore?
so insurance does not allow us to issue an inhaler to an inpatient and then use that same inhaler on discharge. I can't send that home
They
with you.
can't take it.
Insurance won't let us. Do we do it? Maybe sometimes, okay? Because it's real, meds are really expensive, especially
So why do
inhalers.
they do that? They know it's really expensive. And why
Because
can't
insurance
Because
sucks.
of insurance.
Oh, yeah.
Yeah, insurance sucks. There's no rhyme, like, if why do insurance do it? Because they're just greedy bastards, okay? Seriously. So you won't see a lot of inhalers. Now, some hospitals, patients can bring their inhalers in, and then pharmacy usually checks them to make sure they're not expired, and then RT usually goes in to make sure they know how to use them properly, and then some places you can use your home inhalers if you bring them with you, okay? It just depends on what the hospital policy is. And then what happens is that medication shows up on the EMR to be given, but it's not dispensed by the pharmacy, so you won't find it in the vending machine. It's usually in a locked box somewhere, okay? All right. Now during COVID and we were sharing inhalers, there are times when we'll share inhalers, but we use special filters and stuff. Okay, educating patients. So what do we need to do? So you'll hear non-compliant a lot, and I've used it several times because it's easy for you to understand what I mean, right? If I told you somebody's non-compliant, what does that mean?
You're not compliant.
They're not doing what, yeah, they're not following orders, right? They're not doing what they're supposed to do. But a lot of time people don't want to be sick, right? People aren't like, I'm not gonna take that inhaler, I'm gonna be sick instead. No, nobody does that, right? So stop thinking non-compliant, meaning that they're actively going against your orders or your requests or whatever, and think of non-adherence. Like, why is somebody not adhering to the recommendation, okay? And we just identified one. What did we just talk about? Inhalers are what?
That they can't like push it effective?
Yeah, I can't use it,
If they can't afford
I
it.
can't afford it, I don't have access to the pharmacy, I don't have insurance, right? So a lot of people are non-adherent because it's out of their control, okay? So this goes back to understanding what types of medications are you using, what does insurance actually cover, and your pharmacy can help you figure that out. So if you're at the hospital and they're like, I can't afford that, be like, okay, cool. Let me find an alternative medication and check with the pharmacy to see if insurance covers that, and we'll order that instead, right? Okay, if you're not in a mail home system, like let's get your meds mailed to your home, okay? Do you even have electricity? Are you homeless? Right? There's a lot of people that don't have a place to go, or they're transient. So they maybe just got evicted and they're waiting for their new apartment, or they live in 3 different houses, like they're couch surfing. Like this stuff happens all the time. And then they keep coming back to the hospital, not because they want to, just they can't, like this is the bottom of the priority list, right? So don't think of people being non-compliant, meaning they refuse to do it. Just think of non-adherence because they can't do it. Like what's stopping you from being successful at this, right? It creates a whole different conversation in helping patients get to where they need to be, okay? Some people just simply misunderstand, like you saw the inhaler being sprayed to the neck, right? I'm not adherent because I don't know how to use it. I didn't understand that, or I don't know what the medicine's for. So not only are we asking, can you show me how to use your meds, we're asking like, when do you use them? And what did I say about that, right? When I need it, right? Okay, what's the medicine for? It's for my lungs, okay, but what does it actually do, okay? And do they even speak your language? How many of you speak more than one language? None of us? Cool. Some people went to French school, so they're like, I speak French or Spanish. So I always encourage students, if you have another language in your pocket, use it. If you're in an environment where you can, do that, okay?
Only if you know it fluently, yeah.
Yeah, sometimes if it's just about directions, like you can't act as an interpreter, but if it's getting somebody to like follow directions, then you're totally fine. You just can't be official interpreter is all. All right, some other intentional factors, right? Things like they're in denial. I don't really need it, I'm not really sick, I don't want that attention, right? Or perceived lack of benefit, okay? Oftentimes the perceived lack of benefit is because they aren't getting the medication properly, right? So then there's all these other things, I forget, blah, 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 whatever, okay? So don't diminish the patient's experience, just be like, okay, how do we help you be successful? So remember, nobody wants to be sick. Okay. So troubleshooting, so if MBAs aren't going well, what was our first step? Show me how you use it, right? Let's make sure you know how to use it properly. If there's cognitive or physical impairment, the patient can't use it, or ideomotor dyspraxia. So that's like, I know what I wanna do, but I can't make my body do it. It's like when you fall asleep, you're like in your arms asleep, and you're like, I really wanna move my arm, but I can't, and then you like fling it and you hit yourself in the face. Have you never done that? No. All right. So I also have posted in Moodle for you, and I have a hard copy as well. It's called the AARC Guide to Aerosol Delivery Devices for Respiratory Therapists. They have a lot of information in there, and I'll bring in my hard copy that you guys can use during lab, but it is posted in Moodle, and you're gonna want to use that. All right. Troubleshooting inhalers with spacers. Okay, so remember the only thing we use with a valve holding chamber, which is the VHC or spacer, is the medications that depress and spray out. Okay, so the MDIs. Most people in the hospital are gonna make these equivalent things or tell you they don't even know what a valve holding chamber is. Just tell them you're looking for a spacer. You know what the difference is. All right. So some patients put it together wrong, they inhale too rapidly. I told you there's a warning on most of them. They fire multiple puffs into the chamber at a time. We only do 1 puff at a time. So if your prescription is for 4 puffs twice a day, you do 1 puff, wait 1 minute, 1 puff, wait 1 minute, 1 puff, wait 1 minute, 1 puff. Okay, so there's always 1 minute between each dose. We don't go and then inhale all together. Okay, 1 at a time. All right, DPIs. Errors in technique is the #1 reason DPIs are not used properly because patients simply don't know how to use them. All right, part of your job in lab is going through and learning how to use the devices, and I'll answer questions and come through. And then teaching each other how to do it as well, okay? Otherwise, people leave them in their bathrooms, so the devices don't work anymore because they're too humid, okay? Alright, nebulizers, failure to assemble equipment properly, so that could be both you and or the patient if they're doing it at home. Spillage of dose, we did that last week, right? I had you guys all to them sideways. Mm-hmm. I've had more than one patient, I go to the drug vending machine, get the drugs, put them in the cup, I give them the neb, and then they lay down, and the medicine just pours onto the sheet, and I'm like, okay. So we have to start over, now that's a big deal, because I have to call the pharmacy, because you can't now just go suddenly get a second dose all of the time, right? Alright, or they just, failure to keep the mouth in the mouthpiece, right, like I was trying to go talk to you, and like, oh, the medicine's going all over the room, okay. Or they'll do what we call fail to mouth breathe, and you'll know whether or not they're doing that because the mist won't disappear or they can't activate the device. Okay? Alright, let's take a break. That's the end of that one.